Dear colleagues and students, it's our pleasure to continue this continuous medical education of the Ain Shams Neuro Academy. After finishing the stroke and the stroke, multiple sclerosis, movement disorder waves, it's our great honor and pleasure now to have the third wave of the headache and pain. In this wave, we will have our dear guest from Turkey, Professor Mert Akbas, and he is specialized in the pain management from the Department of Anesthesiology. And I will let my dear colleague, Dr. Haitham. Of course, Dr. Haitham is one of our eminent professors specialized in the field of pain, and he had a lot of research and a lot of publications in this area. And afterwards, we will take the Q&A. If you have any questions, just put them in the Q&A. And then we will have a break. And afterwards, Dr. Ramiz will give another presentation about headache and migraine. I will let the floor now for Dr. Haitham to present Dr. Akbas. Please, Dr. Haitham.
Thank you, Dr. Hani. Thank you so much. It's my privilege to introduce Professor Dr. Mert Akbas. Dr. Mert is a professor of anesthesia and pain management at Akdeniz University, Antalya, Turkey. He gained his fellowship in interventional pain management from Center of Pain Management, Texas Technical University, United States of America. He's an algology, which is pain board certified and pain specialist in Turkey since 2007. Dr. Mert is FIPP certified since 2006. And since this time, he's one of the main trainers and examiners of the World Institute of Pain Fellowship. He is the chair of Interventional Pain Management Section at World Institute of Pain. And recently, he was elected as the honorary secretary of the World Pain Institute. He's an internationally recognized speaker. His areas of clinical interest are neuromodulation, including spinal cord stimulation and sacral nerve stimulation, decompressive neuroplasty, trigeminal neuralgia, minimally invasive procedures, and percutaneous cordotomy. Dr. Mert will talk about epiduroscopy and percutaneous slices in spine lesions, mainly with special emphasis and stress on the cervical area. Dr. Mert?
Thank you.
Thank you.
So, can I share my screen?
Yes.
I think it's okay. Can you see it? So, before I start my presentation, I would like to thank the organizing committee as a speaker for this webinar. It's a privilege for me to talk in front of the neurologists also. I am going to talk about lysis procedure, decompressive neuroplasty, epidural neuroplasty. I think this is something will be interesting for you as neurologists. I am going to talk about epiduroscopic lysis, endoscopic lysis, and also percutaneous lysis procedures. So, spinal epidural endoscopic or percutaneous adhesional lysis. Is it all the same? As our population ages and the rate of the spine surgery continues to rise, the use of epidural lysis adhesions has emerged as a popular treatment to treat the spinal stenosis and failed pec surgery syndromes. There is a moderate evidence that percutaneous lysis of adhesions is more effective than conventional epidural steroid injections for failed pec surgery syndrome, spinal stenosis, and lumbar radiculopathies. If we remember the history, the lysis procedure was first invented and described by Dr. Gabor Rags in 1989, which I had the privilege that had to work with him in 2004 also. He described this technique for lysis of epidural adhesions to treat the lumbosacral radicular or low back pain. Since then, it has been used worldwide. This technique is minimally invasive and relatively easy to perform. What are the indications? Failed back surgery syndrome is one of the main indications. Epidural adhesions, epidural fibrosis, spinal stenosis, vertebral body compression fracture, radiculopathies, resistant multi-level degenerative arthritis, and pain unresponsive to spinal cord stimulation or spinal opioids, the general indications. And if we remember the contraindications, the absolute one is sepsis, coagulopathy, local infection at the site of the procedure, and of course, patient refusals, shrinks formation, or chronic infections. The relative ones are cauda equina syndromes, hydrocephaly, unstable angina, obstruction of the sacral canal. It could be difficult for the procedure, spinal dyspharism affecting the area, inability to maintain the position, allergy, severe stenosis, or arachnoiditis. So, lysis of epidural adhesions. If we look at the technique, this technique involves performing an epidurogram to identify the filling defects indicative of epidural scarring and advancing a catheter in the anterolateral epidural space into the adhesions, not in the posterior epidural space. Injecting hyaluronidase, which is the one very important medication for facilitating the adhesionolysis, and normal saline to hydraulically separate the adhesions and wash out the epidural pro-inflammatory cytokines. Injecting anti-inflammatory and analgesic drugs and hypertonic saline to treat pain, inflammation, and edema. So, which techniques are used? We can use for low back pain or lower extremity pain. For epidural adhesion lysis procedure, we can use the caudal approach, we can use the transforaminal approach, or we can use trans S1 approach. And if we remember the medications from the routes we perform, if we perform caudal technique, we use contrast, hyaluronidase with normal saline, local anesthetic with steroid combination, and 10% hypertonic saline infusion. Totally 40 ml volume from the caudal route. If we perform from the transforaminal route, it's about 20-25 ml from the transforaminal route, the total medications. Or from the thoracic level, it's about, again, 25 to 30 ml total medications. I'm not going to talk about cervical for now. I will talk about in later period. So, if we have a look at the studies or reviews, what do they say for percutaneous adhesionolysis in the treatment of lumbar post-surgery syndromes? Manchikanti, who is one of the important pain doctors and has many experience for lysis procedure also. In one of the studies, he performed adhesionolysis in 120 patients. 60 adhesionolysis group, 60 just caudal epidural steroid group. So, when he compares this, 73% of adhesionolysis group had more than 50% relief for 12 months period. Although the caudal group only 12%. And Dr. Hemner, which is one of the important researchers, but unfortunately passed away recent years, he performed a study with 59 patients and divided into 4 groups. 17 patients in group A, he performed hyaluronidase, hypertonic saline. 15 group B, hypertonic saline only. Again, 17 in group C, only isotonic saline, and 10 in group D, hyaluronidase and isotonic saline, because there are different studies comparing hypertonic normal saline. For example, if I give my experience, I began with hypertonic saline, but nowadays only I perform single shot with isotonic saline. So studies show that they are not so much different statistically. So according to Hevener's study, there are improvements in 3 groups. According to the control group, normal saline group, about 50 to 70%. So epidural lysis procedure is effective. Again, Manchikanti with 75 patients. He performed 25 caudal epidural steroid injection. 25 again patient only 1 day adhesional lysis with normal saline, and 25 only 1 day adhesional lysis hypertonic saline. When the lysis procedure were first invented, Dr. Rux advised to perform 3 days lysis procedure. He still supports 3 days lysis procedure, but studies showing that there are not statistically significant difference between 1 day and 3 day lysis. So this studies is important to have a look. So according to Manchikanti studies, 72 of hypertonic saline and 60% of normal saline patients had more than 50% relief at 12 months versus 0% just caudal injection. In another review, if we have a look for percutaneous lysis for post-surgery syndromes, again Manchikanti with 300 chronic resistant low back and lower extremity pain. Again, he performed 2 days adhesional lysis group, 1 day adhesional lysis group, so which he compared 2 day and 1 day, although this is an important study. So it showed that there is no difference between 1 day or 2 day procedure versus reported outcomes of the 3 day procedure. Again, one of the important milestone studies with Dr. Gerdes Meyer from Germany performed a randomized control study with 61 radiculopathy patients, 3 day adhesional lysis protocol, and showed that the OD improved from 67 to 19 at 3 months and 28 at 6 months period. Park et al. In 2011 performed 66 patients who are symptomatic for lumbar spinal stenosis, only 1 day adhesional lysis procedure, and 51% of the patients reported no pain or much improved pain at 6 month period. So all these reviews, all these studies indicate that there is a fair evidence that percutaneous adhesional lysis is effective in relieving low back or leg pain caused by post-surgery syndrome, and that there is fair evidence that percutaneous adhesional lysis is effective in relieving low back or leg pain caused by spinal stenosis. So one of the recent reviews about adhesional lysis for post-surgery syndromes conclude that all these reviews, all these studies performed previously show that this analysis, there is level 1 evidence for percutaneous adhesional lysis, which is very important, based on the evidence from 4 published randomized controls, 3 of the 4 systemic reviews. Also, I would like to mention about one of the lysis procedures which we have performed with my colleagues from Egypt. We compare 3 different techniques, which I mentioned in my beginning of my presentation: the caudal route, S1 foraminal route, and transforaminal route. As a result of this study, there is no different according to anatomical approaches. They have the similar relief, pain relief, but only difference we observe is the experience, especially during performing the S1 foraminal procedure. But results show similar relief. So you have to do the technique which you are better trained. Also, the complications about the lysis study. Dr. Erdine and his colleagues look at the complications, especially for the cervical lumbar and total numbers. I'm going to talk about the lumbar here. They show that all the complications, but the frequent ones, the bending of the tip of the needle, blood aspiration in the epidural space, misplacement of the catheter, numbness, which is transit, and especially infection at the entrance site. So these are the common complications they observed in the studies. So the complications study conclude that the most common complications for the lysis procedures are catheter shearing, dural puncture, intravascular injections, or infections. So, as conclusion, for percutaneous epidural neuroplasty with the RAX catheter is effective for pain reduction and functional improvement in patients with chronic low back and lower extremity pain, which is refractory to conservative treatment and decreases the need for surgical treatment. Also, the recent reviews show that this is level 1 evidence, percutaneous epidural neuroplasty. Now, I want to have a look to the endoscopic lysis. Endoscopic lysis can perform with epiduroscopy. Epiduroscopy is a percutaneous, minimally invasive endoscopic examination of the epidural space that can also be used for therapeutic interventions. So spinal pain syndromes just do not disappear by simply ignoring them. Epiduroscopy offers us a technique for diagnosing and treating the spinal pain syndromes. So, general indications for using epiduroscopy for diagnostic purposes, for therapeutic indications. For diagnostic indications, this may involve distinguishing the pathological and anatomical structures and circumstances, such as epidural fibrosis, following an invasive procedure and radiculopathies. Performing biopsies and smears, removing the irrigation fluid, as well as performing an epidural provocation test. The therapeutic indications with epiduroscopy: direct application of the drugs in the procedure site, lysis of scar tissue, catheter placement, you can do it epidural or intrathecally, implantation of stimulation electrodes during the spinal cord stimulation, you can use the help of epiduroscopy also, or support during the minimally invasive surgical procedure is another therapeutic indication for epiduroscopy. The major contraindications for epiduroscopy is, of course, bleeding tendency, the patients who are under the therapy with anticoagulants, infection in the area of the puncture site, patients who have special neurological disorders, high risk of cardiovascular disease patients, and of course, patient refusal for the procedure. So, when do we have to perform the epidural? Which is the time? When is the time? If the patient has subacute lumbosacral radicular or chronic lumbosacral radicular pain, first of all, we have to perform epidural corticosteroids or radiofrequency treatment. If these treatments are failed, and if the surgical options excluded or contraindicated, and if we all try the optimal pharmacologic treatment, then we can consider to use epiduroscopy at this step. Then, of course, more invasive procedures can be tried after epiduroscopy. So, how does an epiduroscope look like? Here is the schematic view of an epiduroscope. The epiduroscope can be divided into two. One of them is like this, the reusable one, which is very expensive, or there are kind of epiduroscope which is disposable. You can only use it for one procedure, then throw it away. This is, of course, more cost effective than a reusable epiduroscope. And of course, you need an image station, a monitor that, like the monitors you have been using in the endoscopic surgeries. And of course, you have to use C-arm. You have to use it parallelly together, the monitor and the C-arm. And of course, you need your procedure table. All equipments must be ready. So how do we do epiduroscopy? I would like to show pictures because it's an interesting procedure. It's similar like performing a percutaneous caudal RAX catheter procedure. The beginning is the same. First, you have to have a puncture to the sacral canal. Then, the needle is advanced inside the canal, and a guide wire is introduced inside the needle towards the caudal canal. And this guide wire must go in the posterior part of the canal. Then an introducer is advanced through the guide wire. You see the introducer. Then you remove the guide wire, introducer is here, and epiduroscope is ready to advance inside the introducer. And epiduroscope is advancing through the introducer. So what can we see from epiduroscope? Why is it important? As I said, first of all, it is very important also for using diagnostic purposes. Even sometimes the neurosurgeons can ask some help for the patient if the patient really needs procedure or not. So epiduroscopy is really advantages for the diagnosis. You can see the spinal dura mater, which is very shiny. You can see the blood vessels on the dura mater. You can see dura mater with fatty tissues around. You can see the nerve roots inside the epidural area. Or you can see the cauda equina fibers if you enter intrathecally. You can see the neural structures running through the epidural space. Again, nerve in the epidural space. You can see the ligamentum flavum, which is on the left side of the picture. This is the dura mater. Longitudinal ligament here, and fatty tissues, and dura mater. Again, dura mater, posterior longitudinal ligament. So you understand where the problem is or where your lever is, looking at the same time through the C-arm. So C-arm shows your level, which level you are in the thoracic region, in the lumbar region. Sometimes even you can do cervical epiduroscope. And monitor shows you the pathology or normal tissue. You can see the blood vessels, cervical vascular supply, as I told you about the cervical area, or arterial blood vessels in the dorsal epidural area. So mostly we saw in the post-surgery patients, epidural adhesions, you see. Epidural fibrosis, which is much more dense here, and much more dense tissues, scar tissues, you can see in the epidural area. There is nothing to do for the scar tissues. You can see venous epidural pathologies, the obstructed vessels or compressed veins. You can see the inflammatory processes. During the procedure, mostly we think that the scar tissue or epidural fibrosis makes the pain. But in fact, pain mostly comes from the inflammation. I had over 600 procedures with epiduroscope, and most pain occurs with the inflammatory processes. The scar tissue mostly do not make pain. So you can see the radiculosis, which is very painful tissue you see here. Or again, radiculosis in the L3 root, the inflammation here. Again, in the lumbar region, you can see an inflammatory area. Or you can see arachnoiditis. You can see or discover a dural tear. So you can make a blood patch if you see the dural tear at the same time. So if we look at the studies for epiduroscopy and endoscopic lysis, what do they say? This is a very nice study. I like it so much. Epiduroscopy for patients with lumbosacral radicular pain. And also one of the pioneers, researchers, James Hamer, involved in this. So they compared epiduroscopy and MRI for diagnosis and treatment of the chronic radicular pain. So they look which has the advantages during these parameters. The nerve root anatomy, MRI is better. Nerve root perfusion, you can see it clearly with epiduroscope, but you don't have an idea in the MRI. The inflammation, absolutely epiduroscopy. You don't see it clearly in MRI. The accessibility of the nerve root, which is very important for the pain also. You can see it easily with epiduroscope. When you touch the nerve root, the patient says that that's my pain. MRI, you can't understand. Locating the painful nerve root, as I said. Identifying the scar tissue better with epiduroscope. But identifying the herniated disc, epiduroscope, in fact, is not useful. And I don't advise to identify for discs, but MRI is a very important diagnostic tool. Evaluating the diameter of the spinal canal, of course, with MRI, but epiduroscope can give an idea. And of course, excluding the serious pathology, if you are able to take some biopsy, it's possible also. MRI, you can see many things. and you have the therapeutic options with epidural. So, also in this study, the proposed mechanism for the therapeutic efficacy of epidural, what are they? Dilution or washing out the inflammatory mediators that have leaked from the damaged intervertebral disc and facet joint. Also, I had many patients who had annular tear in the disc, and they have pain for many months, but they don't have any surgeries or they don't have nothing and they can't help. But the problem is leaking the disc around the roots, and there is severe inflammation. So you can see it with epidural, and really it's very helpful. Accuracy of placement of a cocktail of steroids or analgesic near the effective nerve. Of course, adhesionalizes increases the mobility of the nerve and restores the supplies of the nutrients and blood to the nerve. And of course, partial denervation of the nerve root or durometer. For epidural, the epidural with adhesional lysis for failed back surgery patients has to be positive. Without adhesional lysis is to be negative. But as I said in my beginning of the presentation, for percutaneous Rux catheter lysis is level 1 evidence. Also, in another study performed by Hema Boscher, one of the pioneers also for the epidural also. In this study, he concluded that epidural is significantly more effective in identifying the ventral epidural scarring than MRI. 80% of the post-surgery patients with persistent low back pain or radiculopathy who had no epidural scarring on MRI had severe scarring found on epidural, which is a very interesting result. Based upon the epidural findings, the incidence of severe scarring after lumbar surgery is at least 83%, and of any scarring at least 95%. Only 40% of patients had scarring demonstrated on MRI. So, in another review for spinal endoscopic adhesional lysis, they concluded that spinal endoscopic adhesional lysis may allow improved nutrition and mobility of lumbar nerves and would allow the delivery of therapeutic medications to the targeted nerve root. So, spinal endoscopic adhesional lysis can be used as an effective treatment modality for chronic refractory low back pain and radiculopathy that is related to epidural adhesions, as we said before. And some other review and studies. Lee performed a retrospective study in 2014 for failed back surgery patients. He performed endoscopic adhesional lysis versus transforaminal epidural steroid injection and concluded that epidural is more effective than transforaminal steroid injection for 6-month period. Igarashi in 2004 prospective study with 58 lumbar stenotic patients with either radicular pain or multisegmental dysesthy. He performed endoscopic lysis of adhesions, and as a result, also he concluded that epidural can relieve pain in degenerative lumbar stenosis. Again, Manchikanti in 1999 with 120 post-surgery syndrome patients. He performed percutaneous and endoscopic adhesional lysis. He compared 2 of them. And as a result, both treatments are effective. But of course, the percutaneous group has more procedures, and it is, which is important, cost-effective than endoscopic lysis. Also, as a result, we can say in this review, the percutaneous adhesionolysis of epidural adhesions to treat the refractory low back and lower extremity pain is a technique whose efficacy has been documented by multiple randomized control studies also. Endoscopic adhesionolysis is a technique which has limited evidence supporting its use, but it is safe and effective procedure with minimal complications when performed by trained practitioners. Of course, it is much more invasive. There can be some immediate complications after the epiduroscopy. You can have epidural space bleeding, you can have a needle damage, penetration of the dura, you have to release, you have to understand if the dura is penetrated. Hypotension, headache, blindness, retinal hemorrhage is one of the important complications. I have been work in a couple of medical legal cases who had retinal hemorrhages after the epiduroscope. The late complications, penetration of the dura, dermatomal sensory or motor loss, bowel or bladder dysfunction, sexual dysfunction, headache, infection at the site of penetration, epidural abscess or hematoma, arachnoiditis. So as a conclusion for epiduroscopy, endoscopic lysis, we can say epiduroscopy is one of the best diagnostic or therapeutic tool for difficult spinal pain syndromes with wider uses in the coming days. We can say epidural endoscopic lysis compared with percutaneous lysis for the, according to evidence base, it's level 2B positive for lysis procedure. But percutaneous lysis is level 1. Also, endoscopic lysis is not as cost effective as percutaneous lysis with catheter. And also, endoscopic lysis should be performed by trained practitioners. It's a epiduroscope procedure and the procedure room you can see. Also, now in this part of my presentation, I want to give a special attention to the percutaneous cervical epidural lysis because it needs some special attention and special interest. It differs from the lumbar lysis procedure. Neck pain is common in the general population. It is disabling and it is costly. The lifetime prevalence of a neck pain has been reported to range from 26% to 71%, with 12-month prevalence estimates ranging from 30 to 50%. Chronic posterior neck and upper extremity pain may result from disc herniation, discogenic pain, spondylosis, spinal stenosis, or post-surgery syndromes. The cervical epidural injection is a commonly used therapy in patients with cervical disc herniation or spinal stenosis. Sometimes the injectate cannot reach the target lesion due to mechanical compression of the structures on the root or epidural perineural fibrosis. So the drugs may be delivered via catheter to the intended location. So epidural neuroplasty for the cervical region using the RACS catheter has the therapeutic effect in patients with cervical disc herniation, central stenosis, post-surgery syndrome who do not respond to fluoroscopically guided simple epidural injections. The indications mostly the same in the lumbar epidural area. But for the cervical area, post-surgery syndrome, the disc disruption, metastatic carcinomas of the spine leading to compression fracture, multi-level degenerative arthritis, facet pain, spinal stenosis, and of course pain unresponsive to spinal cord stimulation and spinal opioids. The contraindications are similar in the lumbar region and the relative ones also. But technique differs from the lumbar region. I want to especially mention about this technique. The patient, after placed in the procedure table in prone position, 18-gauge a puncture needle was placed at the vertebral level C7 T1 or T1 T2 under local anesthesia and advanced to the cervical epidural space using loss of resistance. So the technique referred as 3D technique. It is used to facilitate the entry into the epidural space in the cervical area. The 3D means here direction, depth, direction. Approach is paramedian and it is half level below the target interlaminar space. Advance and direct the needle toward the midpoint of the chosen interlaminar space. You have to check off the depth of the needle with lateral image. Advance the needle toward the epidural space as checking the depth of the needle. You have to look AP and lateral frequently. Obtain an AP view to recheck the direction of the needle. It's an AP view here. So tip of the needle pointed caudally, and after the tip is in the epidural space, you should rotate the tip cephalad and inject the contrast to confirm the entry. Here is the schematic view. The tip of the needle facing caudally. When you enter the epidural area, this is the ligamentum flavum, the tip still is facing caudally, but you should turn it cephalad. But when you turn the needle, you may have a chance to tear the dura. That is the thing we do not want. So you can insert a stylet, a blunt stylet, inside the needle. So this blunt stylet will not damage the dura. It will push the dura away, and you can easily turn the tip of the needle cephalad. So it is ready for advancing a catheter inside the needle. So you can advance the catheter easily. Epidurogram is performed to confirm the filling defects where there is a fibrosis or a scar tissue or where there is any problem. The needle position and specialized epidural catheter is placed directly into the herniated disc level or fibrotic tissue under the C-arm control. After injecting ionic contrast, you have to confirm the proper position of the catheter tip. Here you can see the catheter tip. And again, hyaluronidase, preservative-free normal saline is injected. Here are the volumes for the cervical area. It's about totally 20 ml in the cervical area. The volumes, medication totally injected. But just simple steroid injections, if you have done or if you have observed, they inject only 5 ml. But here, totally 20 ml. So how there is not a problem? So I am going to talk about it slowly. So immediate complications is epidural space bleeding, needle damage, penetration of dura, shearing, catheter hypotension, respiratory depression, mostly similar in the lumbar regions. The late complications are penetration of dura, sensor or motor loss, headache, infection, epidural abscess, or hematome arachnoiditis. And also, again, Dr. Ardina and the colleagues show the complications in the epidural cervical region. Again, the blood aspiration is one of the common ones, misplacement. Hypotension is also common. Transient numbness is a common complication. So, I am going to mention about perivenous counter spread, which is very important in the cervical area. What does it mean? If there is no free flow of injected contrast during the epidurogram, pressure may build up in the lateral epidural space. So characteristic fluid spread by the path of the least resistance can be recognized as perivenous counter spread. The presence of the perivenous counter spread means pressure builds up in the lateral epidural space that is unable to spread laterally to decompress. So pressure may build up and lead to ischemic spinal cord injury. So you have a very short time to rescue from this position. And it's very simple. You see the schematic view of a perivenous counter spread. Fluid is around the cord, and if this volume fluid doesn't go out of the roots, then you have a problem. So how can you save the patient and yourself from the perivenous counter spread? It's simple. Just flexion and rotation of the head and neck can open up the lateral runoff and release the pressure through the enlarged neural foramina. So during the procedure, just you have to do is to say your patient, turn your head to the right and left, your chin to your shoulders. It's just that simple. Rux recommended that the catheter be advanced to the lateral gutter to get runoff of contrast out of the foramen without localization of a contrast. Here's the technique to save the patient from the pressure, just turning the head to right, left, chin to the shoulders. That's simple. It helps to open up the neural foramina. And also, neural flossing exercises. Mostly, you have to advise this simple exercise after the procedure to the patients. It means that neural flossing exercises is just designed to mobilize the nerve roots by sliding them in and out of the foramen. So when you break up the weakened scar tissue with hyaluronidase from the procedure, prevents the further scar tissue deposition. If these exercises are done effectively 3 or 4 times per day for a few months after the procedure, the formation of the scar tissue will be severely restricted. If we have a look at some couple of studies for percutaneous epidural neuroplasty in the cervical area for disc disease. In this study, 80 patients with single cervical disc disease, 2 groups. Simple, one of them is cervical percutaneous epidural lysis, just cervical epidural steroid injection group. And cervical percutaneous epidural lysis was superior to simple epidural injections, better neck disability index, greater reduction in the VAS scores is observed with cervical percutaneous epidural lysis. So this is the demonstration of a simple epidural injection, the medication just in the posterior region, but with a catheter, percutaneous lysis. The catheter is close to the effective nerve root, medication is there, and it's much more helpful. And as the study concluded, the neck disability index, VAS scores, and symptom to relief duration is much better with with percutaneous epidural lysis procedures. Also, in another study for cervical epidural neuroplasty using the RAX catheter, the predictive factors of efficacy of the patients with cervical spinal pain. Also, they concluded here that cervical epidural neuroplasty is an effective treatment for the pain reduction and functional improvements in patients with cervical spinal pain who did not respond to conservative treatments and also may decrease the surgical demand. In another study again, with 123 patients for disc herniation. Also, this study shows better numeric rating scores in the neck pain and arm pain after the procedure. Better neck disability index scores at 3, 6, and 12 months periods. And cervical epidural neuroplasty shows good clinical outcomes in the treatment of cervical disc herniation and can be considered as a treatment modality. Also, this is an interesting study that I want to mention about contrast runoff, which is very important. As we said, for preventing the perivenous contrast spread also. The contrast runoff correlates with the clinical outcome of the cervical epidural neuroplasty using RAX catheter. In this study, the spread of the contrast from the neural foramen to a nerve root was called as contrast runoff. So if the contrast did not spread, there was no contrast runoff. So successful epidural neuroplasty with 50% or greater reduction in the pain and at least 40% reduction in the neck pain and disability scores with contrast runoff patient. Here you can see 1 month, 3 months, 6 months, and 12 months. The patient who does not have contrast runoff and the patient who has the contrast runoff. The ones who has contrast runoff has much better scores. So cervical epidural neuroplasty with contrast runoff had a higher success rate than neuroplasty without a contrast runoff, also which is dangerous, even in the presence of the foraminal stenosis. The physical washout of the inflammatory materials through the foramen is considered necessary for the success. When performing cervical epidural neuroplasty, contrast runoff needs to be present to ensure a successful outcome. So, as a conclusion for this part of the topic also, cervical epidural neuroplasty with a RAX catheter is also effective for pain reduction and functional improvement in patients with chronic posterior neck, upper extremity pain, refractory to the conservative treatment, and decreases the need for surgical treatment. I would like to show just few pictures, which I also performed recently in a cervical disc herniation. Here you see the AP picture. Needle is going between C7 and T1, entering to the epidural area. After you are in the epidural area, you can advance your catheter to the targeted nerve root here, and you begin to inject the contrast. You see the contrast here, and contrast should go out of the root to prevent the pressure over the cord. Here you can use 20 ml volume. It will not have any damage to the patient. Also, it will help for washing out the inflammatory materials. But just simple injection of an epidural steroid from the posterior epidural area is not as effective as this procedure. Here, you tell the patient, turn the head to the right and left, and you see contrast begin to go out of the neural foramen, also from the right and left side. Here, you can see it's much better. It's going out of the root. It's also going up and down. So there is no risk for the patient. Thank you. That's my presentations.
Thank you very much, Dr. Mert, for this comprehensive presentation. And I will let my dear colleague, Dr. Haitham Hamdi, to take the question from the Q&A.
Thank you so much, Dr. Mert.
Thank you.
It was very informative, and it shows the benefits of the minimally invasive procedures in management of cervical and lumbar disc prolapse and post-laminectomy syndrome. I still don't have any questions, so I think the presentation was very simple and informative. So I just checking if I will receive any questions. But I have a question.
Okay.
Is combined caudal and transforaminal lysis is superior to caudal only or transforaminal only? Combining the two procedures together, transforaminal and caudal.
There isn't a compression. There isn't a study who compares this caudal, which is superior or not. Mm-hmm. As we have done in our study, all the techniques from caudal, transforaminal, or S1 approach have similar success rate. Yes. But of course, caudal approach is simply to get trained and to do it easier without, with less complications. Transforaminal and S1 approach needs much more experience. But sometimes you can use two catheter technique in the lumbar area. You can use advanced catheter from the caudal root. If the root open up is not enough, you can use a second catheter from the to the effective nerve root from transforaminally. So you can use the volume from transforamen and also from the caudal root to make the root much more relief.
Mm-hmm. Thank you so much. I have a question from Ramiz. Ramiz is a professor of neurology, and he's specialized in headache. He's asking, when do you decide to do epidural or catheter in acute disc prolapse? When you will decide in acute disc prolapse to do epidural?
Excuse me, I couldn't hear. The voice gone.
Okay, he's asking, Dr. Ramiz is asking, when do you decide to do epiduroscopy or RAX catheter in cases of acute disc prolapse?
For acute disc prolapse, you have to wait a couple of days. You don't have to rush for a procedure. Of course, first option is the catheter technique with RAX catheter. Epiduroscopy needs much more experience and has much more complication rates according to RAX catheter. I personally advise the practitioners try to do it with a catheter first. Endoscopy is helpful. Generally, for my experiences, I advise in the second attempt. Sometimes with the catheter, you may not have a relief. So you will want to find an answer why the patient do not have relief. So at this time, epiduroscope will help because you will see inside the epidural area. You will understand where is the problem, what is the problem, why couldn't I relieve with a catheter. So this time, epiduroscope will help.
Thank you, Dr. Mert. Another question, is RAX adhesiolysis and neuroplasty the only available solution for post-operative lumbar adhesions?
No, of course, in the disc or facet, degenerative facet, spondylolysis, you can use RAX catheter. Spinal stenosis, I prefer to do RAX catheter in the spinal stenosis is also very effective. The patients who do not can go under surgeries or have risk for surgeries, RAX catheter is really helpful.
Okay. No, he's asking if there any other solution for post-lumbar syndrome, post-laminectomy syndrome, rather than RAX catheter. If there any other solutions?
Uh, the other solutions is the basic ones, the epidural steroid injections or transforaminal injections. This is the superior technique and better outcomes than a simple posterior epidural injection or a transforaminal injection. Maybe the doctor is trying to ask about radiofrequency treatment for this procedure. It is not as effective as percutaneous lysis, radiofrequency treatments, or just simple epidural injections.
Thank you. Another question asking about the duration, to how long radiofrequency ablation would be effective for those with mild to moderate disc prolapse and root compression. The duration of efficiency of radiofrequency in cases of disc prolapse. I think he's asking about pulsed radiofrequency for the roots, for the ganglion, in disc prolapse and root compression. The duration of efficacy, how many months?
If you ask me my opinion, it is not effective in that procedure. I do not advise to do radiofrequency.
In root compression?
It's not effective. For this, the radiofrequency treatment is not effective. Radiofrequency treatment is best effective just for the facet pain, also much more effective in the cervical region than the lumbar region.
Another question, what is your protocol regarding medications injected to facet joint and epidural space? What are the medications you usually inject in the facet joint or in the epidural space?
Epidural space, for the lysis procedure, I show the medications. If they are asking their names, you use dexamethasone, non-particular steroid, or steroid. You use hyaluronidase, 1500 unit, 1500 unit. You use normal saline. You don't need to use hypertonic saline. I do not use hypertonic saline because hypertonic saline can cause severe problems. So it's not advisable nowadays. You have the same result with normal saline compared to hypertonic saline. So, just 1% lidocaine as a local anesthetic. The important drug at the lysis procedure is absolutely the hyaluronidase, 1500 unit hyaluronidase. It's really very important. So total volume, the combination of these drugs in the lumbar region is about 40 ml. In the cervical region is about 20 ml.
He's asking about the medications used in cases of facet joint arthropathy. In case of
facet joint, just you make some diagnostic blocks and very small amount, 1 ml, 1% lidocaine. And if you want to use dexamethasone steroid, just use non-particular steroid. And also, you do not need to use a steroid. You can just make radiofrequency thermal lesion. There isn't a special drug for like lysis procedure in the facet joint injection. Just simple 1% lidocaine with combination of maybe little amount of non-particular steroid.
Thank you, Dr. Mert. Another question. If the patient has history of vasovagal attacks, will it limit the use of RAX catheter for the dilatation of the spinal canal? If this is a contraindication for the procedure, having vasovagal attacks?
If the patient is very frequently having this kind of attacks, of course, you mustn't do any procedure. You don't have to do procedure to every patient. First, you have to protect your patient.
Mhm. Another question, the efficiency of RAX adhesiolysis and neuroplasty, is it the same in the lumbar and the cervical region, or it's better in one of the efficiency, the procedure is more effective?
Excuse me, your voice gone again. I couldn't
And
hear.
the person is asking about the efficiency
Yes.
of RAX catheter adhesiolysis and neuroplasty. Is it the
Mhm.
same efficiency in the lumbar and the cervical region, or it's more effective in one of the regions?
The cervical region is much more effective than lumbar region. It's
Cervical is
absolutely,
more
yes.
effective.
Because cervical area does not carry
And
the body weight. That's just very simple.
yes, yes, yes. Another question: if the procedure is also effective in chronic disc prolapse or only in acute disc prolapse?
Chronic in the acute,
The procedure, the RAX.
it's it's both effective, but of course, in the acute disc prolapses, you need to try have to give chance for the medication for at least a couple of days to the patient. Then it is effective, because when the patient is very painful in the acute period, you can't have the chance to perform the procedure. Why? Because patient is having trouble lying in the procedure room.
So I would like to thank very much Dr. Mert for his participation with us today. And it's our great pleasure and honor. And we hope that next time he will be in person with us, either in Ain Shams conference, which will be in September, next September, or in our conference of the Egyptian Society of Neurology, Psychiatry, and Neurosurgery, which is usually held in February. Please, if you have time, Dr. Mert, please stay with us. Dr. Ramiz also will give a presentation about chronic migraine, so you can share with us also the presentation as a discussion. And your contribution, of course, is very important. Now, I would like to present my dear colleague, Dr. Ramiz Reda, Professor of Neurology at Shams University. Dr. Ramiz, of course, he's a well-known professor. He had his PhD from Cambridge, and he started his interest with a stroke, but now he shifted to headache a little bit. I know his passion is always with a stroke. He will give us a talk about modern management of chronic headache and chronic migraine. And if you have any questions, please put these questions in the Q&A, and after the presentation, we will take the questions with you. Please, Dr. Rams.
Thank you very much, Professor Hani Arif. It's a real pleasure to speak, and I'm glad to speak after Professor Mert Akbash, who really gave a very interesting talk. Of course, headache is part of pain syndromes, and we're very happy to have pain being a topic that we discuss. But of course, we go back to our most important part, which is headache, and particularly migraine. We also like to thank our sponsor, Novartis, and we'll speak a bit about modern management of migraine, especially in the era of anti-CGRPs. So I will give a brief talk on this topic. And I'll just share my screen and hello. Sorry for the interruption. So when we speak of prevention of migraine in the era of anti-CGRPs and the modern management of migraine, we need to find treatments that are efficacious and that are tolerated, safe, and the patient can adhere to it for a long time. The main problem with treatment of migraine, particularly chronic migraine in the past, was whether the lack of efficacy or the poor efficacy. Patients did not tolerate the treatments, and as many of you know, very, very poor adherence to treatment, such that only 12% of patients remained on preventive treatment for migraine after 6 months from visiting their doctors. So the challenges that we want to the challenges that we want to solve in migraine prevention in the modern area is to have efficacious treatment that is tolerated, that is safe, and the patient can adhere to it for a long time. Erenumab, of course, is one of the most important anti-CGRP medications, and it's now been in the Egyptian market for more than 1 year, and it's been around, whether in clinical trials or in the market, for about 5 years. So we have a lot of experience with Erenumab, Aimovig. It's an effective treatment across the entire migraine spectrum. Of course, what we see in migraine, we see episodic migraine patients, chronic migraine patients. We sometimes see, of course, the difficult to treat patients, or what we call refractory migraine patients. We also have medication overuse, which is a very common problem with chronic migraine. And we have all the patients with comorbidities in addition to their migraine, and especially chronic migraine. So these are the varieties of migraine patients. And in the past, we did not have any single medication that was efficacious across the spectrum. And also, if we did, it was not tried and tested. Many of you will know that the treatments we use, such as amitriptyline, propranolol, valproate, etc., they were not extensively tested in clinical trials. Most of the data is just case series or clinical practice guidelines, but no clinical trials. But in the modern times, the treatments, especially anti-CGRPs, have gone through extensive clinical trials across a variety of indications, and we can now safely say that all these indications across the migraine spectrum have been tested, and these medications have been found to be very effective. So let me just briefly go through some of the evidence to support the use of anti-CGRPs, particularly Aimovig, Erenumab, across the spectrum. So in patients with episodic migraine, we've seen that Erenumab reduces monthly migraine days. It's very effective in reducing headache by at least 50% in around 40 to 50% of patients. And that's an episodic migraine. But also, this has a very positive impact on the patient's productivity, whether absenteeism or presenteeism, being unable to be productive at work. We also know from the open label extension trials and the long-term studies on Erenumab that it is effective for years and years. And the more patients stay on it, the more effective it becomes. So around patients who improve about more than 50%, and patients who improve about 75%, or patients who improve completely 100%, there's a significant reduction that is sustained over more than 1, 2, or 4 years. And the extension trials, as I said, has now been going on for more than 4 years, and we know that the efficacy of Erenumab is sustained for this period and is not lost after some time. And this is one of the problems we had with some modern treatments, for example, botulinum toxin, that some patients would lose their response to botulinum toxin after some time. But this is not the case in patients receiving anti-CGRPs, particularly Erenumab. Also, it is noticeable that as we continue to give the medication, the number of responders increases and the response improves with time. So, of course, we don't have to keep our patients on the medication for years, but if they stay on it, it seems to improve their response as time goes by. Also, and importantly, Aimovig is very effective in chronic migraine patients, which is really the big problem. 2% of the population have chronic migraine patients. So in Egypt, there are 2 million chronic migraine patients. And it's very nice that we have now treatments that can be used to help this type of patients, reducing their monthly migraine days. Of course, the reduction in monthly migraine days in trials does not seem very impressive, being 2.5 days. But in real life, it seems that it's much, much better than that. And if we take it with how many patients respond by more than 50% or 75%, we find that at least 40 or 50% of our patients will improve that much. Another parameter that we use in treatment of chronic migraine is how many patients are converted to episodic migraine. So patients with chronic migraine who have more than 15 days a month of headache, how many of them convert to episodic migraine? And it seems that about 50% convert within the first 3 months. So over 12 weeks, 3 months, around 50% of patients convert from being chronic migraine patients to episodic migraine patients. Of course, this has a huge impact on productivity, especially work productivity. So patients improve in their disability as measured by the MIDAS scale. So productivity improves a lot. Absenteeism from work is reduced. Presenteeism is reduced, and the patient becomes more productive in his life. And of course, the disability is reduced significantly. Again, as in episodic migraine, also in chronic migraine, this efficacy is sustained. So in the open label trials, we find that patients improve, and if they continue to take the medication, they improve further. They do not lose this response to treatment. If given for more than 1 year, actually the response improves as you continue treatment. Again, some patients should respond with a 50% typical reduction that we measure in trials, but we have to know that there's a big percentage of patients who will improve more than 75%, and that's around 30% of them will improve by more than 3/4, and a considerable 10 to 12% of patients in clinical trials have improved 100%. In real life, this seems to be a larger percentage. We see about 25% of patients improving completely or having 100% reduction of headache days. As we said, there is a spectrum of patients. Some patients with chronic migraine have failed other treatments, for example, topiramate, botulinum toxin, valproate. These patients respond beautifully to anti-CGRPs. They have the same response rates as patients who did not fail prior treatments. So if we compare these, we find that patients who have no treatment failures before Erenumab do not differ a lot from patients with 1 or 2 prior treatment failures. Also, in patients with medication overuse, which is a very common problem with chronic migraine, we find that the same efficacy endpoints are reached in these patients despite the medication overuse. which tells us that we do not need to detoxify patients or stop their medication overuse before treatment. We can just start treatment, and as we can see here, also their use of acute medications will be reduced once they start Erenumab. So we see that acute migraine medications or acute migraine-specific medications such as triptans and ergots are significantly reduced once they start treatment with anti-CGRP. These are patients who have started off with medication overuse and have converted to non-medication overuse. And we see that with treatment with Aimovig at 3 months, we have a significant proportion of patients who convert to non-medication overuse headache. Again, this is reflected very nicely on disability. So patients with medication overuse are usually more disabled. Again, they respond very nicely to Erenumab and their disability is reduced significantly. So we can say that as an effective or efficacious treatment, anti-CGRPs and particularly Erenumab, they've ticked all the boxes in efficacy. They treat all types of migraine, episodic and chronic, and all subtypes, whether they fail treatment or not, whether they've been medication overuse or not. There's a very high percentage of patients that will respond to these types of treatments. And as we said, improvement is shown in many ways, whether the frequency, intensity of headaches, or the improvement in quality of life, or the use of acute medications. There are still subtypes of migraine that the treatment is being tested, such as menstrual-related migraine. But again, it seems that these patients also do respond to treatment. The second important point in a preventive treatment of migraine is whether it's tolerable and safe. And this is really one of the very important points in the new anti-CGRPs, is that they are very, very tolerable and with very, very little side effects. As you know from clinical trials, all the side effects were comparable to placebo. Also in real life data, it seems that Erenumab has very, very little side effects, if at all. Maybe the constipation has been an issue in clinical practice, but about 10 to 11%, so it's not a lot, but generally it's very, very well tolerated. And this has been shown to be, again, true in the 5-year trial. So we see that over 5 years, the treatment is tolerated and also safe over the 5 years period with no really serious side effects. There's a theoretical cardiovascular risk that's been tested and found to be not relevant. So even the cardiovascular risk has been eliminated, which means that we have a very, very safe treatment that we can give for years and enjoy the efficacy without being worried that it's not safe or tolerated by the patient. This, of course, translates into better adherence to treatment. Patients will be more compliant and adherent, and so they will benefit from the treatment and will not stop their treatment as in other types of medication that we've seen before. So as we said, it's placebo-like profile, extremely tolerable, very high long-term safety with no development of antibodies. We still see efficacy after years of use and little adverse events other than placebo. And as we said, this translates into better adherence to treatment. If the treatment is efficacious and tolerated and safe, patients will adhere to it. If they can afford the cost, for example, like insurance covering the treatment, or if they don't have trouble buying the treatment, there is really no good reason that they will stop the treatment unless they get much, much better and decide to try to be off it. But at least in the 6-month period where we want to give them treatment, they will adhere to it, and we will not see the 10 or 12% adherence that we see with oral medication. We will see more than 80 to 90% adherence in patients. As you know, it's very simple to administer Aimovig. It's once a month subcutaneous injection, very simple to give, pre-filled pin. So patients adhere to it and they give it to themselves once a month. If they stay for 3 to 6 months, that means only 6 injections in 6 months. And this facilitates their adherence to the treatment. So, as we said, our expectations from preventive treatment in 2021, modern treatment, future treatment of migraine, of course, anti-CGRPs are not the only treatment for migraine, but they can be used across all the spectrum of migraine patients, and they cover all the 3 important points that we expect from a modern treatment of migraine. Which is that its efficacy is high, tolerability is high, adherence is high, so we can use it when we are treating our patients and not be worried about harming our patients, not be worried about not getting a response and patients losing hope in being treated. In summary, I would say just the key points is that we have a superior reduction in monthly migraine days with Erenumab. We have a lot of patients who respond, almost 100% or at least 3/4 improvement. We have long-term safety data for 5 years or more, and it's a very simple treatment to administer and can be used in patients even with comorbidities in combination with other treatments to help other symptoms. Thank you very much.
Thank you, Dr. Ramiz, for this comprehensive presentation. I will start with a question, and I will encourage also our audience to put their questions in the Q&A box. For the initial or for the episodic migraine, of course, we give a chance for the traditional therapy, 1 or 2 cycles and so before shifting to the monoclonal. So with the chronic migraine, especially, most of those patients already tried many therapies before. Would you give also a trial for the standard medication or the old medication before trying the monoclonal?
Yes, the main benefit of the oral medications is that they treat so many things because, for example, we use propranolol in chronic migraine, and it helps also if the patient is hypertensive, if the patient is tense, if the patient has tachycardia. Same for amitriptyline, we can use it if the patient is anxious or not sleeping well. So treating comorbidities is really where the oral medications are very helpful. So if the patient has not tried oral medications properly before, I would give 1 or 2 trials of oral medications. If they've been tried very well and not tolerated by the patients or have not shown a response, I would start the anti-CGRPs and use some of the oral medications as an add-on with anti-CGRP to help with the comorbidities.
Okay. I have a question from Dr. Abir. What is the role of Botox injection in patients with chronic migraine?
Well, botulinum toxin, of course, is very effective in migraine. In chronic migraine, there have been several trials that showed that Botox is effective in chronic migraine. And of course, it's been approved for more than 10 years now. So we know it's very useful. We know it's very safe as well. The only problem is that patients, if they are given the option between getting injections in their head and just getting 1 subcutaneous injection every month, most patients would prefer the easier treatment. But in my experience, I think, yes, botulinum toxin is very effective. It's very helpful in treating patients. And if the patients take every 3 months the botulinum toxin, they really do benefit from it. Although the problem I've seen is that sometimes, at least 50% of the time, will improve initially, and then maybe after 2 or 3 cycles of injections, we lose the response, which is one of the problems we don't know the reason for, but has been reported everywhere.
Another question from Dr. Yasmin. When it's said that Amovig is failed, and if failed, what to do next?
Well, if we have to try it for 3 months before saying that it's failed. And when we say failed, the definition is that it has not reduced the frequency or intensity of the headaches by at least 50%. So the patient improves 20% in 3 months. That would be, for example, a failure. What to do next? We have to go back to diagnosis, because some of the chronic migraine patients are misdiagnosed. Maybe he does not have, or she does not have chronic migraine. We need to look at comorbidities, of course, and if that's not the problem. So if the diagnosis is correct, there are no comorbidities preventing treatment, and we've corrected our lifestyle, we would go to botulinum toxin injection as an alternative that is, again, efficacious and safe.
Dr. Mona is asking, can we advise Amovig to pregnant or lactating females?
Well, theoretically, there shouldn't be a problem, but of course, at the moment, there have been no trials on this. So it is not recommended, of course, at all to give to pregnant or lactating women, because there is no evidence. But from a scientific, theoretical point of view, there shouldn't be a problem. But until this is tried, whether in real life evidence or in a proper trial, which is not possible, of course, but real life evidence will eventually come out to show us if it's safe or not. I assume it will be safe, but we cannot do this at the moment.
Okay, I cannot see any more questions. Dr. Haytham, you are still with us. If you have any comments or questions.
No, thank you. No, I'm still with you, and I don't have any questions. It was very informative.
Another question actually is popping up from Dr. Abir. How long we can try conventional therapy before trying to the CGRP?
Okay, so each treatment cycle, so we have to do a proper dose and a proper duration. So for example, if we're talking about topiramate, topiramate has to be tried at a proper dose, escalating gradually up to 100, for example, and trying it for at least 2 months. Same for propranolol, triptazole, etc. We have to give a full trial with a good dose, unless it's not tolerated. But if it's tolerated, then we go for a full trial of at least 6 to 8 weeks.
Okay, that's great. So if there is no more questions, I would just like to remind you that as long as we are continuing this COVID era, so we are trying to coming up with new ideas for this educational program. So I guess it would be a nice and new idea to make after each topic, after each section, let's say, headache, stroke, movement disorder, and so on, a wrap-up meeting. So we will make it more or less a hybrid, or even, if possible, in person for the audience, in which we can discuss what was said in these topics and what's new, and to answer your questions, and we'll give and we'll make a good panelist so they can discuss all the issues related to this topic. I guess this is one of the ideas we are coming up with in the next few weeks. Maybe we will start hopefully in Ramadan, and afterwards our next topic will be nerve and muscle, to cover the all areas of our subspecialty. So this is some announcement regarding how we will go on for this Neuro Academy. And I hope you will get benefit from it, especially in this COVID era in which we are having very difficult time on continuing our educational program. So at last, I would like to thank, of course, Dr. Mert from Turkey, and our dear colleagues, Dr. Ramiz for his presentation, and Dr. Haitham for sharing me the moderation. And see you soon in the wrap-up and also in the next wave of Nerve and Muscle. And goodbye, everybody.
Thank you. Thank you so much.
You would like to add anything, Ramiz?
No, thank you, Prof. Thank you. So good.
Okay. Bye-bye.
Bye-bye.